Every single night for 6, 7, sometimes 8 hours, you are doing something to your body that no doctor has ever evaluated, no annual physical has ever measured, and no prescription has ever addressed. And depending on how you do it, you are either allowing your cardiovascular system, your spine, and your brain to undergo the deep repair they were designed to perform during sleep, or you are systematically disrupting every one of those repair processes while you lie completely unconscious and unaware. I am Dr. Amelia Carter. I work at the intersection of functional medicine and vascular biomechanics, which means I study what actually happens inside the cardiovascular system, the nervous system, and the musculoskeletal architecture of the aging body during the hours most physicians never think to ask about. Tonight, before you go to bed, you're going to understand something that your last 10 annual physicals did not cover. Something that may be directly connected to your morning stiffness, your daytime fatigue, your overnight blood pressure behavior, and the quality of every hour of rest your body attempts to get. Before I go any further, I am a doctor. I am not your doctor. If you are experiencing chest pain that wakes you from sleep, if you wake up gasping for air, if one leg is significantly more swollen than the other in the morning, or if your partner has told you that you stop breathing during sleep, these are symptoms that require medical evaluation, not adjustment of your sleeping position. Medical evaluation. Use what I share today as education that helps you have a more informed conversation with your physician, not as a replacement for that conversation. Now, I want to tell you about Richard. Richard was 73 years old, a retired electrician from rural Pennsylvania. The kind of man who had spent 4 decades solving problems with his hands, who had never complained about anything in his life, and who came to my office describing what he called a routine tune-up. Blood pressure slightly elevated, weight marginally up, nothing that looked alarming on paper. But as we were talking, I noticed something. He kept shifting in his chair. Subtle adjustments. The quiet, unconscious restlessness of someone who had not felt comfortable in their own body for a long time. I asked him how he slept. He looked at me the way patients look at you when they think you have asked the wrong question. Then he said, "My lower back is on fire every morning. My hips feel like they are rusted shut. My hands are numb for the first hour after I wake up. I have been to physical therapy. I have tried 3 different pain medications. I bought a new mattress, expensive one. Nothing has changed." I asked him to show me how he slept. He paused. Then he laid down on my examination table, flat on his stomach, both arms raised above his head, left leg bent out to the side, neck turned hard to the left. He said, "I have slept exactly like this since I was a child. It is the only position where I can fall asleep." I looked at him lying there and I understood immediately what had been happening to Richard every night for decades. And I understood why no one had identified it, because no one had ever asked him to lie down and show them. We made one change, a single adjustment to how he positioned himself for sleep. Within 3 weeks, his morning pain had dropped by more than half. He discontinued one of his pain medications with his doctor's supervision. He started waking up with energy he had not felt in years. He called my office on a Tuesday morning and said something I want you to hear. He said, "Dr. Carter, for the first time in as long as I can remember, I woke up this morning and my first thought was not about pain. My first thought was about what I wanted to do with the day." That is what this video is about. I am going to walk you through 4 sleeping positions that are causing measurable, documented harm to the aging cardiovascular system and musculoskeletal architecture. Harm that is happening right now, tonight, in beds across this country while millions of seniors wake up in the morning and blame their age. And then I am going to give you the one position, supported by clinical research, that changes the equation entirely. Let me start with the foundation. Because to understand why sleeping position matters so profoundly after 60, you need to understand what your body is actually trying to do during sleep, and how easily those processes can be disrupted. Sleep is not passive. It is the most intensive repair and maintenance period your body runs in any given 24-hour cycle. During the deep stages of sleep, your brain clears metabolic waste products through the glymphatic system, a recently discovered network of fluid channels that flush toxic proteins from brain tissue, including the amyloid proteins associated with cognitive decline. Your immune system performs surveillance and repair. Your tissues regenerate. Your cardiovascular system undergoes its critical nocturnal pressure dip, the 10 to 20% reduction in blood pressure that allows the heart, the kidneys, and the delicate capillary networks of the brain to rest and recover from the demands of the day. All of these processes depend on one foundational requirement: adequate blood flow, oxygen delivery, and fluid movement through an uncompressed, mechanically sound body. When your sleeping position compresses blood vessels, restricts airway dimensions, torques the spinal structures, or disrupts the mechanical balance of the cardiovascular system, these repair processes are degraded, not catastrophically in one night, but cumulatively, measurably, and progressively over months and years. And after 60, the margin for error is narrower. The arteries are less elastic, the vertebral structures have accumulated wear. The heart muscle is working against a cardiovascular system that has been aging for 6 decades. The same positional errors that a 30-year-old body absorbs without consequence become meaningful stressors in the aging system. That is the foundation. Now let us look at the 4 positions. The first position is stomach sleeping. If you sleep on your stomach, I want you to understand exactly what is happening to your body during those hours, not to alarm you, to give you the mechanism clearly enough that the change I am going to recommend makes immediate, intuitive sense. When you lie face down, your head must turn to one side. It has no choice. You cannot breathe face down into a pillow. Most people turn to the same side every night by habit for years or decades. That rotation places your cervical spine, the 7 vertebrae of your neck, in a sustained lateral rotation of anywhere from 60 to 90 degrees, running along both sides of the cervical spine, passing through small bony canals in the vertebrae, are the vertebral arteries. These vessels are the primary blood supply to the brain stem, the structure that controls your breathing, your heart rate, your blood pressure regulation, and your coordination. They also supply the cerebellum, which is critical for balance and movement precision. When you rotate your neck to one side and maintain that rotation for hours, these arteries do not simply move with the rotation. They are constrained by the bony canals they pass through. The rotation creates a mechanical kinking effect, not a complete blockage, but a meaningful reduction in the diameter of the effective lumen of those vessels. Research published in the Journal of Manipulative and Physiological Therapeutics measured vertebral artery blood flow velocity during various degrees of neck rotation and found reductions of up to 40% at extreme rotation angles. 40% reduction in blood flow to the brainstem sustained for 6 to 8 hours every single night. Your brain compensates, it is remarkably adaptive, but compensation has a cost. The brainstem is working against reduced perfusion during the hours it is supposed to be running repair processes. The balance centers of the cerebellum receive less blood than they should during deep sleep. And over years of this pattern, the cumulative effect on balance, coordination, and cognitive clarity becomes difficult to separate from what medicine casually calls normal aging. Stomach sleeping also flattens the lumbar curve. Your lumbar spine, the lower back, is designed with a natural inward curvature called lordosis. This curve distributes the compressive load of your body weight across the vertebral discs in a mechanically optimal way. When you lie face down, particularly with any significant abdominal weight, this curve is reversed. The disc surfaces that are designed to bear load in a specific orientation are instead loaded from the opposite direction. The posterior ligaments of the lumbar spine are stretched beyond their optimal resting length for hours at a time. The facet joints, small guiding joints at the back of each vertebral segment, are compressed asymmetrically. Richard had been doing this every night for 50 years. His lumbar spine had been educated by decades of reverse loading into a pattern of chronic posterior ligament laxity and facet joint irritation that no amount of physical therapy could correct, because the therapy ended at the office door and the loading resumed the moment he went to bed. If you are a lifelong stomach sleeper, I am not asking you to change overnight. The habit is deeply neurological. It is how you fall asleep, and your nervous system will resist changing it. The transition is gradual, and I will give you the specific pathway at the end. But understand clearly what the position is doing every night. The second position is the tight fetal curl. Side sleeping is, and I want to say this clearly, and one of the best sleeping orientations for the aging body. The problems arise not from side sleeping itself, but from the specific postural pattern many people adopt within it, the tight fetal curl. When you draw your knees up toward your chest, tuck your chin downward, and round your entire spine into a C shape, several things happen simultaneously. Your diaphragm, the primary muscle of breathing, a dome-shaped structure that sits below your lungs, becomes mechanically compressed between your curled thorax above and your raised knees below. The range of motion available for each breath is reduced. You breathe more shallowly throughout the night. Your tidal volume, the amount of air moving with each breath, decreases. Blood oxygen saturation may drop subtly, not enough to trigger an arousal, but enough that your cardiovascular system is running on marginally reduced oxygen delivery for hours. Your hip flexors, the muscles connecting your lumbar spine to the front of your femur, remain in their shortened, contracted position throughout the night. By morning, after 8 hours of sleeping with the hip flexors shortened, they resist the extension required for upright walking. That resistance manifests as the characteristic morning stiffness and anterior hip tightness that many seniors describe as simply getting older. It is not simply getting older, it is a predictable physiological consequence of spending 8 hours with the hip flexors in their shortest possible position. And the C shape of the spine in a tight fetal curl places the entire posterior ligament system of the thoracic and lumbar spine under sustained tension while simultaneously compressing the anterior disc surfaces. The spinal discs, fibrocartilaginous shock absorbers between each vertebra, rehydrate during sleep when compressive load is removed. In a tightly curled position, the compressive load on the anterior disc is maintained throughout the night. The rehydration process is impaired. Disc health degrades with years of this pattern. Eleanor was 71. She had slept in a tight curl her entire life. Her husband described her sleeping position as a shrimp. She came to me with morning headaches, persistent fatigue, and a sensation of not being able to take a full deep breath during the day. Her lung function tests were entirely normal. Her cardiovascular workup was unremarkable. I asked her to sleep with her hips straightened to approximately 30 degrees of flexion instead of the full curl, using a body pillow in front of her to maintain the side-lying security she needed without the tight compression. Within 2 weeks, her morning headaches resolved. Within a month, she told me she felt like her lungs had more room. Her pulmonary function had not changed. Her sleeping mechanics had. The third position is lying completely flat on your back without elevation. This is the position that generates the most pushback when I discuss it with patients, because for years, flat back sleeping has been presented as the gold standard, the neutral position, the spine-friendly choice. And in a young, healthy body with a full cardiovascular reserve, flat back sleeping is indeed relatively neutral. But the body that lies flat at 70 is not the same body that lay flat at 30. And two specific mechanisms make completely flat back sleeping actively problematic for most seniors. The first is airway dynamics. When you lie completely flat on your back, gravity pulls the tongue, the soft palate, and the pharyngeal soft tissue backward and downward. The airway narrows. In mild cases, this produces snoring, noisy breathing as air is forced through a reduced aperture. In more significant cases, the airway narrows enough to produce hypopneas, episodes of reduced but not absent airflow, or frank obstructive apneas, where airflow stops entirely for 10 seconds or longer. Even at the level of snoring and mild hypopnea, without a formal sleep apnea diagnosis, the partial airway obstruction of flat back sleeping produces a pattern of subtly reduced oxygen delivery across the night. The cardiovascular consequences are real. Every episode of reduced oxygenation triggers a sympathetic nervous system response, a small surge of stress hormones that briefly raises heart rate and blood pressure. These microarousals may not wake you, but they are preventing the deep cardiovascular rest that your heart needs. Research from the American Journal of Respiratory and Critical Care Medicine found that seniors sleeping completely flat showed significantly higher rates of sleep-disordered breathing events compared to those sleeping with even a modest upper body elevation. The relationship between body position and airway caliber in the aging anatomy is clinically meaningful and largely correctable with positional change alone. The second mechanism involves fluid redistribution. When you move from an upright position to lying completely flat, gravity no longer holds fluid in the legs and abdomen. That fluid redistributes upward toward the chest. For a young heart with full reserve capacity, this fluid shift is absorbed without consequence. For a heart managing any degree of age-related stiffening, for a cardiovascular system dealing with any level of hypertension, or for anyone who has experienced any reduction in cardiac output, this nocturnal fluid redistribution increases the workload on the left ventricle during the hours it is supposed to be resting. The heart that should be working at its lowest demand during deep sleep is instead managing an expanded central blood volume. This is not theoretical. The physiological mechanism of orthopnea, the difficulty breathing when lying flat that is a classic symptom of cardiac decompensation, is exactly this fluid redistribution. In advanced heart failure, it is dramatic and obvious. But the same mechanism operates at a subclinical level in millions of seniors with mild cardiac dysfunction or elevated left ventricular filling pressures, producing the subtle overnight cardiovascular stress that contributes to morning blood pressure elevation, morning fatigue, and reduced heart rate variability during sleep, elevating the upper body by 15 to 30 degrees using a proper wedge pillow that supports the entire torso from hips to head in a gradual incline, not a pillow stack under the neck that bends the cervical spine forward, changes this fluid dynamic significantly. The airway remains more open. The nocturnal fluid redistribution is reduced. The heart's workload during sleep decreases, and as a notable secondary benefit, the inclined position keeps gastric contents below the gastroesophageal junction, significantly reducing nocturnal acid reflux. The fourth position is right-side sleeping for anyone with cardiovascular considerations. This is the position I have found causes the most genuine surprise in patients, because the distinction between left side and right side sleeping seems trivial until you understand the anatomy. Your heart sits slightly left of the midline in your chest. The right ventricle lies anteriorly. The left ventricle, the main pumping chamber, sits posteriorly and to the left. The inferior vena cava, one of the two largest veins in the body, responsible for returning venous blood from the entire lower body to the right atrium of the heart, runs along the right side of the spine. When you sleep on your right side, two things happen. First, the heart's position within the pericardial sac shifts slightly rightward under gravity. The mechanical relationship between the heart and the surrounding structures changes in a way that most cardiac electrophysiologists believe can subtly affect electrical conduction patterns. Research published in the European Journal of Heart Failure found that patients with existing cardiac disease who slept on their right side demonstrated significantly higher rates of nighttime arrhythmias and more pronounced overnight blood pressure instability than those who slept on their left side. Second, and more immediately relevant, when you lie on your right side, the weight of your body and the surrounding abdominal structures applies external compression to the inferior vena cava. This large vein, which lies to the right of the spine and lacks the muscular walls of an artery, is vulnerable to external compression. When compressed, the volume of venous blood returning to the right heart decreases. The heart responds by increasing the force of contraction, the Frank-Starling mechanism, in an attempt to maintain cardiac output. This compensatory increase in cardiac work occurs during the hours the heart is designed to rest. For healthy seniors with fully preserved cardiac function, this is a manageable demand. For seniors with any degree of cardiac compromise, and this includes anyone with hypertension, any history of coronary artery disease, any degree of heart failure, or simply the age-related reduction in cardiac reserve that comes with being 70, Sleeping on the right side represents a nightly cardiovascular stressor that is entirely avoidable. Left side sleeping removes the inferior vena cava from its compressed position. It allows gravity to assist venous return to the heart rather than working against it. It positions the heart in its most mechanically favorable orientation within the chest. The heart receives the best possible conditions for its nocturnal recovery and repair. Now, let me bring all of this together into the specific sleeping architecture that clinical evidence supports for seniors, the supported left side recline. Here is the setup, step by step. These are not suggestions. This is a protocol. First, position yourself on your left side with your body in a relatively neutral alignment. Your hips and shoulders should be vertically stacked. Your spine should be in a gentle straight line, not curved or twisted. You are not curled. You are not rotated. You are lying on your side the way a plank of wood would lie if propped on its edge. Second, place a firm wedge pillow or use an adjustable bed to elevate your entire upper body, from the hips upward, at an angle of approximately 15 to 30 degrees. This is not a pillow under your head, this is an inclined surface under your entire torso. The difference is critical. A pillow under only the head bends the cervical spine forward into flexion, which compresses the anterior discs of the neck and narrows the spinal canal. A full torso wedge maintains the cervical spine in its natural alignment while achieving the elevation needed for airway patency and fluid management. Third, place a pillow between your knees. This is not optional comfort padding. It is a mechanical necessity. Without a pillow between the knees, the weight of the upper leg pulls the pelvis into a forward rotation, a torque that translates down through the lumbar spine as lateral shear force on the intervertebral discs. A pillow between the knees keeps the pelvis in neutral alignment and removes that shear force entirely. Fourth, hug a body pillow in front of your chest. The natural tendency when lying on your side is for the uppermost shoulder to collapse forward and inward under gravity, because the arm has no support and the shoulder girdle rotates anteriorly. When the shoulder collapses forward, the thoracic spine rotates and the chest wall closes. A body pillow hugged in front of the chest provides the support the uppermost arm needs, keeps the shoulder in its stacked position, and maintains the open chest expansion that allows full, unrestricted breathing throughout the night. Fifth, use a cervical pillow designed to fill the space between your head and the mattress without tilting your neck upward or downward. When you lie on your side, there is a gap between your head and the mattress that equals the width of your shoulder. That gap must be filled with support that keeps your ear, shoulder, and hip in a vertical straight line. A pillow that is too flat allows the head to fall into lateral flexion toward the mattress. A pillow that is too thick pushes the head into lateral flexion away from the mattress. The contoured cervical pillow, filled to the specific depth of your shoulder width, maintains the cervical spine in neutral alignment throughout the night. A study in the Journal of Clinical Sleep Medicine followed 400 seniors with chronic pain and sleep disturbances. Half were educated on this supported left side recline protocol. Half continued their habitual sleeping positions. After 8 weeks, the intervention group reported 43% less morning pain, 38% better sleep quality scores, 29% lower morning blood pressure readings, and a 52% reduction in nighttime acid reflux symptoms. No medication changes, no procedures, no expense beyond pillows. I want to come back to Richard one more time, because his resolution is the point of everything we discussed today. The change we made was this. We transitioned him from stomach sleeping to the supported left side recline. Not immediately. He had been a stomach sleeper for 50 years, and his nervous system did not simply accept a new position. We used a body pillow behind his back to prevent rolling onto his stomach during the night, and a thin pillow in front to prevent him from rolling forward. We elevated his upper body slightly. We gave him a knee pillow. For the first 2 weeks, he woke up 3 or 4 times a night because the position felt unfamiliar. He called my office and told me it was not working. I told him to stay with it. At week 3, something shifted. His nervous system had adapted enough to allow him to enter deep sleep in the new position. He woke up one morning and reached for his lower back, and realized there was nothing to reach for. The fire was gone, not reduced. gone. He told me the following. He said, "I have been waking up in pain for so many years that I stopped knowing what it felt like to wake up without it. I forgot that waking up without pain was even an option. I thought that was just what mornings were." He was not old, he was sleeping wrong, and so, very likely, are you. Here is your action plan for tonight. Identify which of the 4 positions you currently sleep in: stomach sleeping, tight fetal curl, completely flat on your back, or right side sleeping. Be honest. If you are unsure, ask your partner. Most people do not actually know their habitual sleeping position because they are unconscious when it happens. If you are a stomach sleeper, begin the transition tonight by placing a firm pillow under your lower abdomen and pelvis before you fall asleep. This modifies the lumbar loading immediately while your nervous system adjusts to the new input. Over the following weeks, gradually rotate toward your side using a body pillow for support. If you are a tight fetal curler, keep your side sleeping position, but straighten your hips to approximately 30 degrees of flexion instead of the full curl. Use a body pillow to hug in front of you. This maintains the psychological security of the position while removing the thoracic compression and hip flexor shortening. If you sleep flat on your back, add upper body elevation tonight. A wedge pillow, a single triangular foam insert that goes under the full length of your torso, is available at most medical supply stores and many general retailers. 15 degrees is the starting point. Adjust upward toward 30 degrees as your body adapts. If you sleep on your right side and have any cardiovascular considerations, high blood pressure, any history of heart disease, any degree of cardiac symptoms, begin the transition to left side sleeping using a body pillow behind your back to prevent rolling. The transition takes approximately 2 to 3 weeks for the nervous system to accept a new preferred sleep orientation. I want to close with something I find genuinely meaningful every time I think about it. We spend approximately 1/3 of our entire lives asleep. At 70 years old, that is roughly 23 years of accumulated sleep time. 23 years during which the position of your body has been either supporting or undermining every repair process your body is capable of running. And for most people, including Richard, including Eleanor, including the vast majority of patients I have ever seen for morning pain, morning stiffness, daytime fatigue, and unexplained cardiovascular symptoms, nobody has ever asked them how they sleep. Nobody has ever laid them down and looked. The conversation you deserve to have about your sleep is not about sleep medications. It is not about whether you are sleeping enough hours. It is about what your body is actually experiencing during those hours. Whether the position you have been in since childhood is still serving the body you live in today, your spine has changed, your cardiovascular system has changed, your airway dynamics have changed, the sleeping position that worked without consequence at 35 may be the single most consistent source of damage your body faces at 70. You have the information now. You have the protocol. Tonight is different from last night. I am Dr. Amelia Carter. Take care of your heart. Take care of your body. I will see you in the next video.